All right, this is Senate Health and Welfare. We're back and we're moving on to H72, an act relating to a harm reduction criminal justice response to drug use. And we have two guests with us online, Dr. Marshall and Dr. Kroll. And I'm going to ask each of you, I have you in order, Dr. Marshall going first and then Dr. Kroll. Do either of you have a time crunch at this point or frame? Or...
Oh, that's no, you've got me all morning, so happy to be here. Good. Yeah.
And I'm on the West Coast, so it's early here, and I'm all clear.
Terrific. So, great. So, Dr. Marshall, you're here with us. Why don't you, we're going to introduce ourselves to you so you know who you're speaking with, and then we'll ask you to introduce yourself for the record. So I'm Senator Ginny Lyons. I chair the committee, and I'm from the Chittenden Southeast District in Vermont. Senator, go ahead.
Oh, hi. I am Senator Martine LaRocque-Gulick, and I live in Burlington, Vermont. I represent Chittenden Central.
Good morning, Dave Waits, representing Rutland County. Terry Williams, also representing Rutland County.
And good morning, Dr. Marshall. I've met you before. I'm Senator Ruth Hardy. I represent the Addison District.
Okay. So we are hearing first from Dr. Marshall. Why don't you introduce yourself for the record, and then we look forward to your testimony. And before you begin, I'll ask both of you, have you sent your testimony in writing to our committee assistant?
I did send my slides, yes, not a written testimony, but happy to do that afterwards if helpful.
And
I have not done yet that. I didn't realize I needed to do that. So I will send my slides. Do you need me to do that before I speak or afterwards? It's fine.
Well, you can, if you're going to go through them and have them up on the screen for us, that'll be fine, but then send them afterwards. That would be very helpful. And it allows for us to listen rather than try to take notes as you speak. We'll probably do that.
Yeah, I plan on having them up. Though we'll need to be able to share screen to do that. But yes, I definitely will have my slides.
All right, so Dr. Marshall.
Sure. Thanks so much, everyone. I'm really happy to be here today. My name is Brandon Marshall. I'm a professor of epidemiology at the Brown University School of Public Health in Providence, Rhode Island. I'm also co-leading an evaluation of overdose prevention centers in New York City and the forthcoming facility in Providence. So what I hope to do today is share with you some of the international evidence behind overdose prevention centers, and then I'll be handing it over to my colleague and friend, Alex Kroll, to talk about some of the domestic research that he's done and that has been done in New York City. So just to put us all on the same page here, overdose prevention centers are spaces where people can consume pre-obtained substances under the supervision of trained staff. These staff intervene in the event of an overdose or some other medical emergency. They may administer oxygen or naloxone, for example, to reverse an opioid overdose. But what's important to keep in mind is that overdose prevention centers offer a lot of other resources and referrals to programs as well, including access to medical care and other referrals to treatment and recovery support services. This is not a new intervention by any means. There are more than 200 overdose prevention centers operating in more than 14 countries. The first facility opened in Switzerland in the 1980s. And in Europe, they're more commonly referred to as drug consumption rooms. You might hear the term supervised consumption facility, but I'll be using the overdose prevention center today. So I want to talk a little bit about why this public health intervention may be a benefit to Vermonters, really for two reasons. The first is that unfortunately, like in much of the country, the number and rate of opioid-related overdose deaths in Vermont has continued to grow and has reached an unprecedented high in 2022. And these are data from the state health department. So clearly the crisis continues to be a major public health problem in Vermont, just like in the rest of New England, honestly. And of course, we have lots of interventions to try to address this problem. One, for example, is naloxone, which is an effective opioid overdose antidote. Part of the problem, though, is that to be effective, someone needs to be present to administer naloxone and to reverse that overdose. And these are data I pulled from a recent report from the Vermont Health Department, showing that of all of the people who have died of an overdose over the last 10 years in Vermont, more than 40% had no one nearby who could intervene, administer naloxone, and call 911. So these are really the group of people who may benefit the most from overdose prevention centers. The hope, right, is that if an OPC had been available to them, rather than using alone, they may have used in a supervised, safe environment, which could have saved their lives. So I'm going to talk just a little bit about some of the Canadian and also French research that's been conducted to examine the outcomes of overdose prevention centers. I'm going to take you inside the first overdose prevention center that was opened in Vancouver in September 2003, more than 20 years ago. So this is what the facility looks like. This is what is called a fixed site model. This is a large facility. You can see 12 booths in the background of the photo where people can use pre-obtained substances. And in the foreground of the photo, you see the nursing station that allows trained professionals to passively observe people using and intervene in the event of an overdose. They also provide education, basic health care, wound care, and also sterile use equipment, which is shown in the bottom of the figure. There are a lot of other modalities of overdose prevention centers, though, that I do want to highlight. This is an example from my hometown, which is a smaller town in British Columbia of about 150,000 people. This is a mobile overdose prevention center, basically a converted RV, which can be effective in communities where there's a more dispersed population of people who are at risk for overdose. So you can see the two booths in the foreground of the photo, and then other medical services can be provided in the mobile OPC as well. On the other side of the figure is what's called an integrated OPC. This one is integrated into a primary healthcare clinic for people living with HIV. In Europe, overdose has been integrated into hospitals and emergency departments too.
Could you repeat that?
This is an example of a rural OPC that operates in northern Alberta, 500 miles north of Edmonton, in a town called Grand Prairie. You can see just how desolate and rural it is in the figure. They have a mobile overdose prevention center that again is a converted van, basically. This is the inside of that van. Again, two supervised consumption booths, a lot of supplies and services for medical provision. It's also very busy. Over 2.5 years, they've had almost 30,000 visits from 450 people and more than 400 overdose interventions with no deaths. So these can be effectively implemented in more suburban and even rural communities where we see a high level of overdose mortality. So I just want to talk a little bit about two pieces of research that have been conducted and then hand it over to Dr. Krall, who will talk about some US specific evidence. So we know that overdoses can be effectively managed in facilities by providing oxygen and naloxone, for example. But one question that we sought to answer was whether OPCs actually have an impact on community overdose rates. So that's what we sought to answer and published this study in The Lancet way back in 2011. In this study, myself and colleagues were able to map where overdoses were occurring in the city of Vancouver. And we basically looked at the neighborhood level overdose rates before and after an overdose prevention center opened. So this is what we found in that study. We stratified the data by neighborhoods that were very close to the overdose prevention center, less than 500 meters or about 500 yards from the OPC, because we knew that's where the vast majority of people using the facility resided, and compared that set of neighborhoods to the rest of the city of Vancouver overall. And what we found was a 35% reduction in community overdose mortality after the Overdose Prevention Center opened in the neighborhoods within its immediate vicinity, compared to only a 9% reduction in the city of Vancouver overall during that same time period. And a recent study that was just published in Lancet Public Health a few months ago found a similar finding. As overdose prevention centers have been implemented in Toronto, they've observed significant reductions in community overdose mortality in those neighborhoods too. This is just a visual of what it looks like. So this is the downtown Eastside neighborhood. This is the neighborhood of interest. The red star represents the location of the overdose prevention center. The darker the color, the higher the overdose mortality rate. And what we found was that after the facility opened in September 2003, we observed reductions in overdose mortality in every single block in this neighborhood. I also want to highlight this other really lovely study that looked at longer-term trends in mortality among people using overdose prevention centers in Vancouver. This is a large study of more than 2,000 people who use drugs in Vancouver. They've been followed prospectively for more than 10 years. And what this study found was that people who used the Overdose Prevention Center at least weekly had a 54% reduction in the risk of all-cause mortality compared to people who did not use the facility that frequently. And this effect was independent of many other major risk factors for mortality among people who use drugs. I want to note here that of all of the 112 deaths that were observed, only 17% were actually due to overdoses. The other causes of death were liver-related diseases, suicide, HIV, and other causes. And so we see a potential protective effect of overdose prevention centers, both on other causes of mortality and beyond just using the facility itself. And this is because of the other services that are provided as people use the OPC. All right, so just one other research question that I wanted to introduce before handing it over to Dr. Kral, which is whether and how OPCs help people enter into treatment. This is a major public health goal of overdose prevention centers. I showed you the consumption room. What I did not show you was the post-consumption room, where we have trained professionals, peer recovery support specialists, or psychologists or other professionals working with people to understand what health services they need and whether they're interested into treatment. So that was a question that this group of researchers sought to answer also from Vancouver. They followed more than 600 people who were not accessing any form of substance use disorder treatment as they started to use the Overdose Prevention Center. And what they found was that after about 2 years, more than 40% of people had started to enroll in some kind of SUD treatment. And when they looked at the factors that predicted uptake of SUD treatment, they found that the more regularly someone used, and importantly, whether they had contact with peer counselors who worked at the site, were both some of the primary factors that increased the likelihood of accessing treatment. Anything to the right of the value of 1 here was a factor that was associated with an increased uptake of treatment. And so that's really important, right? You can see here that more regularly contacting an overdose prevention center and then building rapport with and speaking with counselors who work at the facility is a really effective pathway into SUD treatment for many people. This is the last research study that I wanted to highlight. This is one of my favorite ones from Lade. It was published last year. It's a really nice design. It was conducted in France, looking at people who inject drugs and who use 2 overdose prevention centers. And they compared those people who use needle and syringe programs in other cities in France. And they looked at a number of outcomes. They found that among people who used an overdose prevention center, overdoses went down by 67%, and also skin and soft tissue infections went down by almost 80%. And this is a major issue as xylazine has entered into the drug supply. We see really tremendously severe skin and soft tissue infections. And so by providing a safe place to use injecting equipment and basic healthcare, we can see reductions in these very challenging and very expensive conditions to treat. And then they also found reductions in emergency room visits as well as among people who used OPC. And this is important because we know that with a strained healthcare system, anything we can do to reduce strain on emergency rooms is going to be a good thing, right? And so we see this reduction because overdoses can be effectively managed on site. They don't require a visit to the emergency room or the hospital. So I just want to finish by talking about what's going on in Providence. We were the first state in the nation to authorize overdose prevention centers through legislation. That was signed into the law by the governor in 2021. That law did a number of things. It required the health department to establish regulations that would license and oversee the operation of overdose prevention centers. So those are publicly available. The link is there, and I'm happy to share those regulations with the committee and with the health department after the presentation, if that would be helpful. The law also required that any organization that wishes to open an overdose prevention center would obtain municipal level approval. So that's what was done most recently. In February, the City Council of Providence, our capital city, unanimously voted to approve an overdose prevention center in Providence. So that's where we are today. That approval forward, and the building has been secured. It's beside Rhode Island Hospital. Construction has started. I'm happy to report on implementing this service, and likely I want to note funding was made available for this service through our opioid settlement dollars as well. About $2.6 million from our settlement was allocated to OPCs. So that's all I have for you. I just want to highlight some of the funding that we've received, which we're very grateful for, from the National Institute on Drug Abuse, which funds our evaluation for the next 4 years of facilities in New York City and Rhode Island. We also receive funding from the NIH more broadly and from the Open Society Foundations. And if you have any questions for me after, I'm happy to be available to you. There's my email and also our team's website as well. So that's all I have for you. Hopefully that wasn't too long. I can try to figure out how to stop sharing. And I'm happy to answer questions now or hand it over to Dr. Krall.
But why don't we go through and listen to Dr. Krall and then come back and perhaps we'll get into a discussion. This is very helpful. I think, obviously diving deeper into the research that you have, in particular with respect to the legislative language that you were talking about for Department of Health might be useful. So we'll go over to Dr. Krall and then come back for questions and discussions. And thank you very much. This is very enlightening.
Thank you, Dr. Marshall. My name is Alex Krall. I am also, like Dr. Marshall, an epidemiologist. I've been conducting research on drug use and drug policy here in the United States for 30 years now. I am based at the nonprofit called RTI International, which is a research institute based out of North Carolina. But I'm in a West Coast office. And over the last 10 years, I've been involved in most of the work that's been evaluating overdose prevention centers here in the US. What you're going to find is that Dr. Marshall did such a great job laying out the international work, and really probably we can summarize all the data I will show you by saying that all of the things that they found internationally, we've also found domestically, and many of the same things, the same numbers, the same associations, which is interesting because sometimes we feel like here in the US we're somehow different than other countries, and we don't have the same healthcare. Maybe we don't have, we have different kinds of situations, and so it's important for us to know what has been going on specifically in the US. There have been 4 evaluations, actually 3 evaluations in the US so far. The first is one that we carried out at what was an unsanctioned OPS in an unnamed city, unnamed because because of the legal questioning, whether it was illegal or not. The site did not want to know, want everyone to know where it was, but nonetheless, it was the first site in the United States, and so we did an evaluation there. The second is the first sanctioned site, which was, started in New York City at the end of 2021, where they have 2 sites in Manhattan, and that is ongoing. And then the last is a site in San Francisco, which is where I am, which was sanctioned and was a pilot project that was just open for 46 weeks, just shy of about a year in 2022. So I'm going to share a little bit of the research from each of these, as well as just a summary of some of the cost effectiveness studies that have been done by people around the country, including Dr. Marshall. So the unsanctioned site operated and really opened in 2014. So now, wow, that's 10 years ago. In an unnamed city, they had two separate rooms, one for injection and one for post-injection, where counseling could happen and people could be for a bit. They had these 6 stainless steel tables. They had trained staff who were stationed in each room, and sterile equipment and all the things that Dr. Marshall talked about, really from perspective of what was at the Vancouver site. And they also had a tablet for inputting data, and so we were able to get data from that. Here's a paper we published in the New England Journal of Medicine in 2020 on that, from that site. There were just over 10,000 injection events at that site over those years. There were 33 overdoses, and all of those people survived. And in fact, none of them required 911 to be called, because they were all, all reversed and saved by the trained people who worked at the site. But we also did a study in that city of 500 people who inject drugs, and we basically compared people in the city who used the site to people who did not use the site. And we followed them over time. We interviewed them at baseline, at 6 months, and at 12 months. And we did a series of studies looking at that. And much like Dr. Marshall's research, in fact, what he showed there in France, what we found in that site was that people who used the site were much less likely, significantly likely, to visit emergency departments. They had fewer emergency department visits. They were less likely to be hospitalized, and they had 50% fewer nights in a hospital. So we saw some great benefits from that. We also did a study looking at syringe sharing and rushed injections, and also isolated injection drug use. These are kinds of behaviors that lead to either infectious disease or overdose. And while we found some lower rates, these were not statistically significant, but we did certainly find lower rates of syringe sharing, injecting in isolated locations, and rush injections among the people who used the site as compared to those who did not. Then the other piece, about these sites is not just what happens to the people who go to them, but also, what happens in the neighborhoods. And I'm going to be really breaking up some of the research that we're showing here by both what happens to the people who use them, and then how does that translate into what happens in the neighborhoods. And what we find here among the people who used the site was that they had 58% lower rates of number of improperly disposed syringes in the neighborhood. So that's basically a question that's asking if how many needles they've left on the streets, in alleys, in parks, and in public areas. And so there were much fewer of those syringes by the people who used the site as compared to those who did not. And then we also did a study looking at crime in that particular city. This is a fancy kind of looking graphs here. What we have is, what you're looking at is, we basically compared all the drug-related crimes in the city from the year 2010 to 2019. And so it's a 10-year period, of which you see a dotted vertical line is the 5-year point. And that's actually when this OPS or safe consumption site opened. And so we had data 5 years prior, and we had 5 years after they opened this OPS. And the green line is, again, a 500 meter. We use the same sort of size of area as Dr. Marshall's study up in Vancouver. And what we found was that crime was increasing prior to the opening in that neighborhood in green, and then actually started decreasing in that neighborhood post the opening of the OPS. And that's compared to the blue lines below that. And that's another neighborhood that has a similar kind of resource center in that city, but does not have an overdose prevention site. And there you essentially see a flat before and after line. We also compared to another adjacent neighborhood, which is what you see in the red there. Again, the green up top is the numbers in the of crime in the around the site. And then we saw similar actually up and then going down in an adjacent neighborhood. And so our conclusion is that certainly crime seems to go down rather than up in these sites. And certainly isn't any different from other neighborhoods in that same city as well. So then just kind of summarizing those data, these OPS definitely helped the people who used them by preventing overdose deaths, preventing emergency department use and hospitalization. And they also helped the neighborhoods in which they were located by reducing crime and syringes in public settings. In New York then, and Dr. Marshall, you talked a little bit about, mentioned the New York sites. The New York site's the first, site that was sanctioned in the United States. I'm really just summarizing the peer-reviewed research here. And so I only have the only paper they have on the actual effectiveness of it currently in peer review is this one right here, which was just from the first 2 months of operation of these two sites. But in just those 2 months, they had 6,000 drug consumption events happen at the sites, and these sites allow both injection and smoking. They have a smoking vestibule there that each of those sites as well that people can use. And in those 2 months, they had 54 overdose interventions. And again, with naloxone or oxygen, and again, no fatalities, which is what we keep seeing internationally and nationally. That everyone who's using these drugs at these sites, if they overdose, they're being saved right then and there. In New York, they've also looked at the issue of the neighborhood and looking at crime and disorder around these sites. And a research team from NYU published a paper just a few months ago, 6 months ago, looking at crime. And what they did was they compared the neighborhoods around the OPCs, the two OPCs, to neighborhoods around syringe service programs. And so these are other programs that essentially see the same clients, the same people come to them. And so they're good neighborhoods as comparison because they're also using these kinds of services. It's just they don't have the availability of the overdose prevention site. And what they found was no significant changes pre and post the site's opening with respect to violent crimes or property crimes recorded by police, by no changes in 911 calls for crime or medical incidents, and also no changes in 311 calls for drug use or unsanitary conditions observed in the vicinity of the OPCs as compared to the syringe service programs. They also saw, they did see a significant decline in low-level drug use enforcement in the area. So there was a reduction of arrests for drug possession actually near the OPCs, quite a large one, an 83% a change there. And also in the broader neighborhoods of 74%. And they did look at criminal court summons as well and found that there were significant declines in those around that area as well, of 87%, 89%, 87.9% that you see there, and 59% in the neighborhoods around them. And so they really found very positive impact on the neighborhoods around these sites. So the last evaluation study I'm going to share some data with was in San Francisco. This is a site that was opened by the mayor of San Francisco in January of 2022. And she did that as a declaration, an emergency declaration, and she did it as a just temporary, really a one-year project to see, to assess what was going on in the Tenderloin area there, and they called it the Tenderloin Center, or TLC. And that was really put in the central part of the city and had an outdoor OPS, which could actually, there could be up to 50 people using the site at once. And so it's a very large site probably the largest that I've seen internationally as well. And so the pilot was just 46 weeks. It was, I guess, now a little bit over a year ago. And we did the evaluation for that. We had a few different kinds of research questions, wondering, will people come to such a site? Would they use the services? Will they feel comfortable spending time at this place? Because those were some of the questions people had ahead of time. What we found in just 46 weeks, so this is less than a year, was 124,000 visits. That's a lot of visits right there. And that the average person who went to the center would spend 1.7 hours there. And actually, among the people who used the overdose prevention part of this center, the average amount of time, or the median number of time that they spent there was almost 3 hours. So this also had the effect of actually having about 18,000 hours of people being spent a month at the site, as opposed to out and about in public settings, which is one of the current concerns they had in San Francisco, was sort of this public drug use and those kinds of issues. And so they wanted to see, can we get people off the streets and certainly seemed like it was an effective way to do that. They had a lot of different services, as Dr. Marshall talked about. These sites do vary around the world in terms of what kinds of services provide. There was a lot of services provided at this site. You see over that time, 12,000 visits for behavioral health. We're at the site. Almost 7,000 people accessed housing and shelter support type services they had at the site. There were medical doctors there, so there you see that. And other social services as well, about 7,500 people accessing those kinds of services. So people were certainly comfortable with coming there. They went there. They used the various services that were there in that various ways. Next, the question we keep kind of getting back to is, well, do people overdose at this site? And what happens to the people that overdose at the site? And we just published a paper on that in the International Journal of Drug Policy. And during this 46-week period, you saw how many visits there were. There were 333 overdoses, and to the right here, this is a weekly number of overdoses during the 46 weeks. And what you see there is a lot of variation, and a lot of that variation has to do with things like the drug supply, and all of a sudden, what happens in cities, and they do go up and down quite a bit, and it's kind of interesting to just be able to see that in and of itself. Of the 333 overdoses, and you're probably getting tired of hearing this, but should not be tired of it. No people died again, right? So we keep seeing that no one's dying at these sites. The San Francisco site had a policy of that when people overdosed, they required the center for most of it to call 911 services, and so 75% of these actually involved calling 911. But I will say that was really unnecessary, as we've seen in other sites around the world, and also the unsanctioned site. You don't really need 911 services. And that's one of the things that's really good about these sites in general, is that you actually save the healthcare system and the city a lot of money by not needing that 911. Now, certainly, there are going to be cases where maybe 911 is needed, and certainly they would call then if that's needed. But this was a regulation they had that was really unnecessary, and ended up making the emergency system, the ambulance system, quite unhappy, because they felt like they needed to keep coming to this place. As you see, 333 overdoses. But their services weren't actually needed, and so that was a contentious thing. So that's something I think I like to point out to legislators as they're considering these kinds of sites, is that's not a necessary aspect of it. People always wonder, is there this sort of honeypot effect that you put one of these sites in a place, and it's going to bring all kinds of people from all over the place to the area? So we also had a couple of research questions about, will this site bring people from other neighborhoods? And then the other piece that we've talked about as well is, is there going to be an increase in public drug use and needles around the area if you do this, if you implement this sort of a thing. For a couple of months there, we asked all the guests exactly where they were coming from, and 96% of the visits were coming from the two neighborhoods that were really straddling. The center straddled two neighborhoods, the Tenderloin and the South of Market centers, and they just about everybody came from very close by. People are not going very far to go to these sites, which is what they found also in New York. I will say they haven't published that data quite yet, but they find the same thing in New York. That people don't travel very far to go to these sites. And then we did a similar thing here where what we did was to look at the neighborhood and look whether this brings more drug users and brings more, drug use to an area. We did an analysis here where we took these 500-meter radiuses, which is about 500 yards, as Dr. Marshall said, around the Tenderloin Center. And then we had a comparison neighborhood, which is in Dason neighborhood, where there was this place called the Mission Neighborhood Resource Center, which is also a center for homeless people, but they don't have an OPS at that site. And then we had research assistants walk every block in a 500-meter radius there to record all drug use, all homelessness, any drug use equipment they find, any of that kinds of things on these blocks. And we actually did this in 2018 and 2019, which preceded this. And then we did it again in 2022, just 6 months after the opening of the overdose prevention sites. And so we had 2 years prior, and then we had 1 year post opening this site. And what we found here is if we start with the blue is the Mission Neighborhood Resource Center, which is the control, right? This is the area that's a homeless resource center that does not have an overdose prevention site. And if you see here the data in 2018, 2019, and 2022, basically found the exact same, it was completely flat, the exact same amount of public drug use and drug use equipment on the blocks in the 500-meter area around that site. However, in the site where in the area neighborhood where the overdose prevention center was open, there had been an increase from 2018 to 2019. We didn't do this study in 2020 and 2021 because of COVID and the shelter in place, and these neighborhoods look very different in those 2 years. But then, as I said, in 2022, 6 months after the opening of the site, we redid the study there, and actually it was significantly down back to 2018 levels. So if anything, public drug use went down from 2019 to 2022 in that particular area that had the overdose prevention site. The last thing, and I just want to throw a couple more little numbers at you, but this is just a summary of some of the cost effectiveness studies that have been done in the United States, looking at what happens if you put one of these sites in your city, in your area, what will be the costs, what will be the savings. In San Francisco, we found a net of just one site, a $3.5 million net savings by having just one of these sites. In Baltimore, they found an almost $8 million annual savings. In Providence, this is part of Dr. Marshall's work. They found that it would save $1 million annually compared to just having a syringe service program. So adding this component to essentially a service program. And then in New York City, they estimated that one site would save between $800,000 and $1.6 million annually, and that 4 sites, which is what they proposed at the time, would save between $3 and $6 million annually. And so this is one of the things I wanted to add to this. Okay, well, that's just a quick summary here then. The science is rigorous and extensive on these programs around the world, and also on the handful of sites that have opened in the US. Every peer-reviewed study has found positive impact of OPS, both on the people who use them and in the communities in which they're placed. No peer-reviewed scientific studies have found any negative impacts of OPS. That's pretty amazing, I have to tell you. When you look at and doing these kinds of studies, and Dr. Marshall and I have done many studies, we can't think of any other studies really, or any other kind of intervention where we don't find any negative impact. I mean, even if you were to look at the drug treatment literature, you would find some negative things actually, which we all take to be obviously we all think drug treatment is a great thing, but it's hard to do, and there have been so many studies and they haven't found any negative effects. Want to acknowledge a lot of my co-authors on these studies, but also funding from All Ventures and from the San Francisco Department of Public Health, and thank these organizations that have allowed us to be part of their, to evaluate them, because that's a little bit of burden on these organizations as well. And I'm happy to take questions as well. So thank you very much.
Thank you very much. Both of your presentations were terrific and summarize a lot of research in a short period of time. So I know we all have questions, and at the end, you indicated that there were no negative effects, but along the way, there must have been some barriers that had to be overcome. So one of the ongoing concerns that we hear in our state, as well as possibly others, is we don't want this in our town, or we don't want this in our neighborhood. And how were those issues handled? And did you confront any of that information as you were doing your research?
Would you like me to start, Alex, or?
Sure, you can start.
Yeah, that is an important to consider, what we call a NIMBYism, not in my backyard. And we've seen that happen in some settings like Philadelphia that have aimed to implement overdose prevention centers. I think it's really important to solicit that community buy-in and to make sure that neighbors understand the public health goals of these facilities. We've had success with that in Providence. We've, been involved to educate the public. The organization that is opening the overdose prevention center has been canvassing door to door and, educating neighbors, businesses, and residents on what they intend to do. And I think that's so critical. People really like to be in the know and to learn. I think you're always going to have some opposition, but in my experience, a lot of people just don't know very much about these facilities. So once you walk through their goals, how effective they are, and the benefits they have to the neighborhood, you can really move the needle and shift a lot of minds through that kind of work. But it does take time and it does take effort, for sure.
And I would add to that, yeah, I mean, while the research shows these are all, very effective and they help both the neighborhoods and the people who are in them, that doesn't necessarily filter out to community members, as Dr. Marshall said, and people don't get to know that. And so I think it's a matter of maybe publicizing quite a bit about these things, as he mentioned as well. And where you cite these do matter. You don't sort of put this, next to a school in a residential neighborhood necessarily, right? And that's been an issue, and certainly was an issue, I will say, for the San Francisco site, which was plunked down right on Market Street, right in the, next to the Civic Center, the City Hall, and there was a lot of neighbors that were very upset about it, and it was a pilot for a year, and San Francisco has not put up another one since, even though the health department has it in their plan, in their overdose prevention plan, to open more of these sites. They have not found spaces, the right spaces to do that, and part of that was because this was put into place that was certainly, politically, it was highly visible. There were lots of people and people visiting the city, and workers were walking by, and all of that. Whereas if you look at the New York sites, they're in much better locations, I would say. That are away from a little bit off the beaten path, and in neighborhoods that have a strong need as well. And so I think it does that. And I think, as Dr. Marshall, and you can speak more to this, the Providence site is not in a residential neighborhood. You should speak more to that. But the site there is, I think, it sounds ideal. Maybe you want to talk a little bit about that process in Providence.
Yeah, thanks, Dr. Krull. So that was a challenge, honestly, for us, and partly, to be totally frank, is what has been so slow in Rhode Island. I mentioned we passed the law in 2021. and much of the delays have been trying to find an appropriate building. And so were several options that were being considered, and this building became available. It's directly beside Rhode Island Hospital, our largest and only tertiary care center, which I think has a lot of benefits. People being discharged from the hospital for an overdose could be referred directly to the Overdose Prevention Center for additional referrals and care. So that's an opportunity. And then in the reverse, people who need more advanced clinical care for wounds or infections could be referred to a hospital-based setting as well. So I think the location that has been chosen is very good. A couple others that were on the table, though, included one where a methadone clinic currently is and was going to move, and so the Overdose Prevention Center would have taken over that facility. And that move just became very slow, to be honest. So the timeline wasn't going to work out. But I think that can be a way to go as well. You can look at where are the existing services for people who are at risk for overdose and try to locate overdose prevention centers there.
Thank you. I think because that is a question, what you've just talked about are questions that we're hearing about from our community members, some of our community members. So it's important for us to understand the process that you went through and what you think is important in establishing some of these. So I have a lot of questions, but I think your research covered some of them. The one question I have, and I'm not sure, and I know others on the committee want to ask questions, but the payment for the services you indicated came out of the opioid settlement funds, I think in Providence. That's what is looked at there. Can you talk a little bit about the funding over a longer period of time, sort of the sustainable funding that may or may not be available and how you're looking at that?
Yeah. The funding piece is key. I'd like to say these do take investment. They, especially to implement an OPC, as Dr. Krall showed, they do have significant cost savings, especially to the healthcare system through averted emergency room visits and hospitalization. So that's always important to keep in our mind, is that they have been found to be cost-saving interventions, but they do require operating dollars. And so we are using the opioid settlement funds to launch these facilities. But as you know, it's like an 18-year tail of funding that does decrease over those 18 years. And so we're investigating, or the state is investigating, some longer-term funding strategies, including, for example, we have a tax on opioid prescriptions, which I believe Vermont has as well. So that is a potentially sustainable funding model. As well as private philanthropy. Project Web Renew, the organization that's opening the OBC, just 2 days ago received $1 million from Jeff Bezos's ex-wife's organization, Mackenzie Scott. So, that is a model I know that's happening in New York, as well as to look to a combination of both health department funding and private philanthropy as well.
Okay, thank you. I do want to let others have an opportunity. Senator William J.
I've got a couple of questions. Thank you for your testimony. They clarified a lot of questions I had, but one of the questions is, do any of these sites have drug testing equipment for the test their substance for opioid? I didn't hear that in testimony, but I may have missed it.
Contaminants.
Yeah, that's a great question. I really like that you asked that question. As scientists, we like to, and really all the things that we presented today were things that had been studied and had been gone through scientific peer review. And so we didn't touch upon really everything, but we really wanted to stick to what do we know scientifically to be true. And there haven't been studies in the US yet of that. But yes, first of all, these sites have the San Francisco site did, and the New York sites do, and the unnamed city site did as well. All of them had these test strips, the fentanyl test strips, that people can use themselves to test the drug solution themselves to see whether it has, say, fentanyl in it. For sure. In terms of the community-based FTIR machines, which are, basically much fancier, more expensive, sort of $50,000 machines where you can test not just yes, no, does it have fentanyl, but rather exactly what is in the drug solution that you have. The New York site did get those. Brandon, is it both the sites or is it just one of the, I think it's both the sites now that they've got one of those machines, I think, right?
Yeah. I think
Yeah,
so.
and that happened just a few months ago, I think. And so they haven't I haven't seen any research on that yet. But they do have those machines there. I will say that the syringe service programs in San Francisco, there is the main program there has two of those machines, but during that period in 2022, the organization that ran that site did not have one of those FTIR testing machines, but they certainly were planned to have that. If you're going to do another site, there's no question that would be part of what they do have as part of that.
And my second question is, I think society would like to believe that eventually this drug addiction problem is going to go away. This is a tool to help that. I see it as I have a simple mind: prevention, treatment for those that are addicted, and then in conjunction with a recovery program. Do your OPCs work in conjunction with the recovery program?
Yes, and that's how I like to think about this crisis as well. You're completely right that we need a multifaceted set of strategies that focus on prevention, treatment, and they should not work in silos with each other, right? So yes, the organization that will be operating the OPC in Providence is a harm reduction organization, but they also provide a lot of recovery-based services. And in fact, the majority of their staff identify as people in recovery. So they're going to be integrating a lot of treatment and recovery-based services directly into their overdose prevention center. The director of the center in New York likes to say that the moment someone expresses a willingness or an interest in treatment, every single staff member who works at that OPC in New York City is ready to take advantage of that window of willingness or that opportunity and connect them to treatment and recovery services. So that is happening, and we're going to be studying over a longer term the effectiveness of that kind of approach. But yes, integration of harm reduction services with treatment and recovery is really, I would say, a best practice and should be done in these kinds of sites. Alex, anything to add there? Yeah.
I do have something to add to that. And I agree with everything Dr. Marshall said. The San Francisco site for that year was run by the largest nonprofit treatment organization in California, Health Right 360. That's who actually ran the overdose prevention site in San Francisco. And so they were intricately linked to treatment in a very structural way. I'm not saying that all OPSs need to be run by drug treatment programs, but I agree with Dr. Marshall that these programs are a great opportunity for people to get into treatment. It would be a wasted opportunity to have these sites. I actually do believe these sites were fine even without that, because you're saving lives, and so I think they're important in and of themselves. But to just do that is a wasted opportunity. Here you have a lot of people who do need treatment, maybe not all of them, but many of them, and many people who are ready. When they're ready for treatment, then it should be as easy to get into treatment as it is to buy drugs. And so if you are at these sites and you're using drugs and you're ready and want treatment, it should be very easy to do that, and that I think is an important component of these sites.
So thank you. I mean, having longitudinal analysis of that is going to be extremely helpful, I think, going forward. Our state has what are known as hubs and spokes. And so some association somehow makes a lot of sense. It doesn't necessarily have to be a hospital or clinic. And so what I'm going to say is I'm going to let Senator Hardy ask a question when I finish, but then I'm wondering if you might be available going forward as we continue our work on the bill and to help us understand some of the nuance that you've experienced either in establishing or in studying these centers. Would you be available at a future time? And that would be great. I know the question I asked about NIMBY is front and center. The question you answered in your slides on crime is another one, retail theft and so on. And I don't think that we've heard enough about mobile centers and how those work. So it would be great to have you come back in if we can do that. And I'll turn it over to Senator Hardy as a question.
Thank you,
I
Madam.
can just add one thing to that. I'm happy to come back anytime. Happy to do this as many times as you'd like, as it's useful for you. And I think maybe even coupling having us researchers on here, but coupling that with, say, the executive director of Sam Rivera of the New York sites, because he can speak very passionately to how they made those decisions, what their relationship is. And I know I've heard him speak before about, their amazing relationship with the police in the neighborhood, with a school. They actually have a school nearby, one of those two sites, and they have a great relationship with the school and what it takes to do that. What Dr. Marshall talked about earlier in terms of, the importance of doing that work ahead of time, of having that community input, of assuring people and also asking what the people in the neighborhoods need with respect to these sites and figuring out ways to provide those kinds of things. And so that would be I think an excellent person to speak as well. As well as the executive director, Vitka Eisen in San Francisco. She would be, I'm sure, happy to speak as well and about their implementation and some of the thoughts that went into that.
So that's terrific. We have a long list already, and I think some of them are already on it. So we'll continue with that. Thank you.
Oh, thank you. And I just want to echo what the chair said about wanting a little bit more information about the mobile sites. I know, Dr. Marshall, you've done work in Canada about that, and I serve on our opioid settlement committee, and you've shared some more details with us about those mobile sites. And I would like to have this committee hear some more about those, because part of our proposal is that one of the sites would be a mobile site. And I'd love to get more information on how those work and how they, because they're not a fixed site, how people find them and how they're scheduled, et cetera, so that we can really start to visualize how that would work here in very rural parts of Vermont. So that's probably more than you can address today, but and then one of the things that really struck me as I've been reading more recently is that not only are overdoses prevented at these sites, but the way they're prevented is so interesting. And I know neither of you are, well, maybe you are medical doctors. Yes, sorry, or not. No, you're not. Okay. That they're basically by providing oxygen and microdoses of naloxone instead of the really hard dose of a Narcan that you often would see in an emergency situation outside of a site, so that they're actually preventing overdoses without making people go into that shock of needing to use again so quickly. And I'm losing the correct words, but I found that really fascinating that and super helpful, because that helps people recover more quickly and maybe feel the need for getting into treatment more quickly. So I wonder if there's any specific research on that. And then lastly, also very interested in more data on the impact of, you mentioned it in your slides, but the reduction in emergency room usage and the reduction in first responders, the use of ambulance and police and EMS, because that is a huge issue in Burlington, where if this bill passes, one of these sites would probably be located, and wanting to know more about that data, about the reduction of the use of those services and how that benefits, those benefits from these sites.
This is good, and so we'll add that to the list of things that we would like to have you comment on. So obviously, going through the bill, we're going to get to these questions about what type of harm reduction is being offered in the centers and at what level. So there are a lot of things that we need to understand further. And Senator Weeks, I will give you that chance to ask a short question.
Good, thank you. Thank you. So first off, good briefing. Certainly a lot of information, a lot of data, very well presented, and I appreciate that. I do have a question based on the premise that one of the goals as a state government is to reduce or remove drug dependencies. And I'm wondering that the only metric that I thought was lacking in your joint presentation was something which links your effort and the effort of prevention and recovery efforts to return patients to a meaningful and self-sufficient lifestyle. I get it that the first one that pops up would be they're still alive, but it's got to be a longer term view. And I'm wondering, and I may not have the time to address this this morning, but that's really to me the core of whether the effort, all this effort and all this treasury is appropriately addressing the reduction or removal of drug dependency and restoration of meaningful life.
So I'm gonna say, I think you did address that very briefly when you answered Senator Williams' question, and it is a question that I think is also important. It's one thing to have short-term harm reduction. It's another thing to have longer-term linkages with treatment and recovery. So can we hold that? Do you want to give a short response? That was good.
Yeah, I'll just say, this has been extremely helpful for me in terms of where the need for data is. So I'll take that back to our team and we can prepare some more information for you that hits on these points, because we're very interested in studying these longer term trajectories, but there are some existing studies as well that I can. That's an important thing. We want to save lives today. We do want to provide a pathway for people as well to achieve better health over the long term. So I'm here to help, and we'll prepare that information for you, and happy to come back as well anytime that I can be helpful.
That's a great answer. Just a quick thing is, again, we've focused on the science of what exists in the science. It's a tough thing to study. We all agree with that. It's a great goal. Most of these sites, you can come in anonymously. You can come in not giving your names and things. And so in order to follow people for a long period of time to see what happens over 2 or 5 years or something like that, it's from a research perspective difficult to follow people that long to see what happens to their lives in the long term, which is why the data is a bit lacking on that. But we agree that that's an important endeavor.
All right, thank you very much. Again, we really appreciate the time you've given us this morning. And it's early out there. It's still early. So we will invite you back, and we'll pay attention to the time. When I saw Research Triangle Park, I thought immediately of North Carolina, right?
Yeah, we are.
So,
we are headquartered there, but I don't mind getting up in the morning. I don't mind at all. I'm up anyway.
All right, terrific. So thank you very much. We appreciate it. And we'll see you next time. We have you and a call back.
Thank you.
Thanks so much, everyone.
Thank
Take
you
care.
very much.
That's good.
Bye-bye.
All right. So do you know where Martine went?
I
Can you just check her? I want to come back to S18 and see if we can do that. So we're going to go offline, but we're not leaving the